My name is Fernanda and I'm an attending physician at Hospital Israelita Albert Einstein in São Paulo, Brazil. On behalf of my co-authors, I would like to thank the editorial board of Gastrointestinal Endoscopy for the opportunity to discuss our upcoming article entitled Metal versus Plastic Stents for Anastomotic Biliary Strictures After Liver Transplantation, a randomized controlled trial. Biliary lesions with a reported incidence of 15 to 40% are the most frequent complications after liver transplant and remain the major causes of morbidity, graft loss, and mortality. Among them, biliary anastomotic strictures are the most common, affecting 15 to 20% of patients after deceased donor liver transplant. Nowadays, non-surgical approaches have largely replaced reoperations as the initial treatment for biliary complications. Endoscopic therapy is definitely the preferred first-line modality for patients with duct-to-duct anastomosis. Currently, endoscopic management is based on dilation followed by plastic stents placement. The major drawback of endoscopic treatment with multiple plastic stents is the need for repeated procedures. That is time-consuming, reduces patients' compliances, and increases costs. In this scenario, covered self-expandable metallic stents have emerged as an appealing option for benign biliary strictures, especially for those not responding to endoscopic standard therapy. Why did we feel a need to do the study? Well, by the time we started the study, there was no prospective trial comparing covered self-expandable metal stents to multiple plastic stents in the management of biliary anastomotic strictures after liver transplantation. And as I said before, covered metal stents have become a very attractive option since they definitely have longer patency and their removability had already been demonstrated. The possibility of treating patients with one single stent and only 2 interventions was very provocative. Having that said, we decided to design and conduct a single-center prospective randomized controlled trial in Hospital Israelita Albert Einstein in São Paulo, Brazil. Our aim was to compare efficacy and safety of covered metal stents versus multiple plastic stents for post-liver transplantation biliary anastomotic strictures. Patients were randomized to covered self-expandable metal stents or to multiple plastic stents. In the first group, the metal stent was deployed with or without sphincterotomy, and dilation was not performed unless necessary. Stent removal was scheduled after 6 months stent indwelling. In the second group, we have adopted an aggressive plastic stents exchange protocol. During a 1-year period, ERCP was repeated every 3 to 4 months when the stricture was dilated and an increasing number and larger diameter stents were progressively replaced. Sometimes we even dilated over a stent in order to achieve the maximum bile duct diameter. After stricture resolution, which was the study primary endpoint, patients were followed for at least 1 year. Why did we decide to calculate the stenting area? Because the stenting area is the most accurate measure to determine the surface achieved with both treatment options. The average stenting area accomplished at the final ERCP was 78.5 square millimeters for one 10 millimeter metal stent and 52.2 square millimeters in the multiple plastic stents group. This graphic presents the progressive increase of the stenting area in the multiple plastic stents patients. Not all patients had 5 ERCPs. Therefore, taking into account the last procedure, the final stenting area reached was 52.2 square millimeters. Considering the area calculated for each stent, such a large total area can be achieved by placing, for example, 6 French stents or a series of other combinations. What does our study add to the existing knowledge? I will remark some crucial points. First of all, both therapies were equally effective regarding stricture resolution. Concerning complications, we have noticed an increased incidence of post-procedure acute pancreatitis after transpapillary metal stent placement without sphincterotomy in the first 16 cases. The protocol was changed. Sphincterotomy was then performed in all patients, drastically reducing this complication rate. This observation is limited by the number of patients, but still very remarkable. With a median follow-up of almost 3 years, 32% of recurrence was observed in the metal stent and none in the plastic stents group. There are some possible explanations for such a high recurrence rate. First, it could be secondary to stricter intrinsic factors such as fibrosis, ischemia, the presence of suture material, or any other, although this variable would be equally distributed between groups due to randomization. Second, the fine staining area could be important. However, metal stents led to a larger fine staining area than multiple plastic stents, making this explanation less probable. Finally, and that's our actual explanation, the lower recurrence rate after multiple plastic stents treatment was secondary to the longer treatment duration, maintaining dilation and remodeling the structure. It is clear to us that studies leaving the metal stent for a longer period are necessary. And last but not least, the median treatment cost was 60% cheaper in the metal stent group, demonstrated a clear positive impact in cost. What was the major study limitation? The variable period of stent indwelling, according to treatment allocation, was the biggest study limitation. Based on the current knowledge at the time the study began, we chose a 6-month period for stent indwelling to assure we would not experience difficulties during stent removal. What should come next? A longer metal stent indwelling should be studied. As a matter of fact, we have an ongoing study to evaluate the metal stent performance after 1 year indwelling. But in order to be successful, we probably need metal stents with better anti-migration design. In the long run, we should be looking towards one single self-expandable biodegradable stent to be placed in one procedure with no need for sphincterotomy. In summary, our study was able to demonstrate that both therapies were equally effective regarding biliary anastomotic stricture resolution. The main advantages of metal stents proved to be lower cost and the reduced number of procedures. Sphincterotomy must be performed in all post-liver transplant patients with strictures before transpapillary metal stent placement. Treatment duration with covered metal stents for more than 6 months should be further investigated. Thank you for watching our video.